Clark, W number 0282160.
And I'm Katie Borland, W number 0126828.
And we are assessing the eyes, ears, nose, and throat.
And also the musculoskeletal system.
So I'm going to start the eye exam. Prior to beginning the eye exam, we want to ask if the patient has any problem seeing, double vision, if they are wearing glasses or contacts, if they have had any eye trauma, or if they had any eye appointments lately. So first we want to assess the eyes to make sure that the eyelids and the eyelashes are turned outwards. We want to ensure that the eyelid itself is in the correct position and it's not endotropion or ectotropion. And for our corneal reflex, we'll take this cotton ball, we'll bring it from the inner to outward. We want to ensure that blinking is happening so that we know that the cornea is intact. With our pen light, we will assess the pupils. So we'll shine it directly into the eye, and we're making sure that the pupils are equal, round, reactive to light, and accommodating. We then want to test for peripheral vision. We'll have the patient cover one eye, and we'll bring the pen past the ear and towards the nose. This should be at a 90-degree angle, and they should be able to see it probably between the ear and the eye itself. I'm now going to assess the eyeball by pulling this down gently. I should see that the conjunctive is pink and moist, and also that the sclera has a blue-white color. Sometimes in elderly patients it does have a yellow tinge, and we also don't want to see bright yellow because that could indicate jaundice. Testing for muscle weakness within the eye, we would start with our pen light, and we would put it in the 6 cardinal directions. 1, 2, 3, 4, 5, 6. Now this will be about 30 centimeters away from the face, and if we saw any nystagmus, which is a twitchy eye movement, that could indicate brain lesion, MS. It could even indicate narcotic use. Although we do not have a Snellen chart currently present, we would ask the patient to look at the Snellen chart from 6 meters away to detect if they have any visual deficiencies. So with the ophthalmoscope, I will turn it on and adjust it accordingly. I will look into the patient's eye to ensure that there's no abnormalities and ensure that the optic nerve is intact and that the color is an orange-red pinky color. This is the Snellen chart. It tests the eye's clarity and acuity. The term 20/20 vision is what a normal human should be able to see when standing 20 feet away. 20/40 vision is half the norm, and 20/10 vision is 2 times the norm, which means it's twice as good. So we're now assessing the ear, and before doing the assessment, we want to make sure that we ask the proper questions. We want to know if the person has had problem hearing, if they've had any drainage, if they've recently cleaned their ears or used Q-tips. And we also want to know if they've had any previous hearing problems. We want to test look at the external ear to make sure that there's no redness, that there's no visible earwax, and that there is no drainage. If there is drainage, this could mean that there is otorrhea. With our otoscope, we hold it upside down and towards the ear. This helps stabilize it. It is uncomfortable at first, but you do get used to it the more you do it. Looking into the otoscope, we want to see that the tympanic membrane is translucent and has a pearly gray color to it. This shows that there is no infection. So we're now going to do hearing testing. So for this, we'll ask the patient to occlude one ear, and I would whisper a 2-syllable word, and I would ask them to repeat it. If they could not repeat the 2-syllable word, this would indicate that their hearing is not good. In our ear assessment, we also want to test for equilibrium. So with that, we would do our Romberg test, which consists of having the patient stand with their feet side by side and their eyes closed, open, and then you'd have them open and close them again for probably about 15 to 30 seconds. This being said, it's usually normal to be a little bit unsteady, but if this person is completely losing their balance, that definitely means that there is something wrong with their equilibrium. Now, if our patient was a head trauma case and had been having maybe like a blood tinged or a clear fluid coming from the ear, this is very dangerous because it could be cerebral spinal fluid. This being said, it does have an oily texture and it would test positive on a blood glucose strip. So if this is the case, your patient will need to seek medical attention immediately.
I'm going to be assessing the nose and throat, and the first thing we're going to ask our patient, obviously we're going to do our hand hygiene and explain our procedure, and although this is just a continuation on from the eyes and the ears, the first thing we're going to do is ask some questions. Is the patient experiencing any nasal drainage? Are they having any severe or frequent colds? Is there any trauma to the nose? Is there a deviated septum? Do they suffer from allergies or hay fever? And is there any change of the sense of smell? So first we're going to assess each nair of the patient, and we'll do that by just asking the patient to flex their head backwards, and we're going to lightly touch the nose and tilt it back so we can observe each nair with some sort of light source, whether it's the otoscope or just a pen light. So I'm just going to do that. I'll just tilt their head back. I'm going to observe their nairs to make sure that they are pink and moist. Now they won't be the same as in the mouth. In the mouth would be a little bit more pink, and the nose will be a little bit less pink. So now I'm just going to palpate the patient's sinuses. Just going to go over the eyebrows here. They should feel a little pressure but no pain, and just under the eyes here as well. Again, maybe a little pressure but no pain unless there is some sort of infection brewing. So now we're just going to do a smell test with the patient. We can do this with different things. We can do this with cheese or flowers or anything, but Rebecca and I will do this with just an alcohol swab. We'll get the patient to close their eyes. We will hold the alcohol swab and just under their nose, and they will tell us alcohol, or they don't smell anything, or anything like that. So now moving on to the mouth, we're going to first inspect and observe, and we're looking for any cracked lips, which would cheiliosis. We're making sure that there's no hoarseness in the way that they speak. Is this patient a smoker? If so, how much do they smoke? And then we will be examining inside the mouth. We will be looking for the normal buccal mucosa would be a pinkish color, but we want to make sure that there's no thrush, that there is no raised bumps, any unusual spots, any painful cankers. So on top of all those things I've just discussed, we're also going to be looking for symmetry in the face. Anything asymmetrical in the mouth or in the face in general could indicate that there is a neurological issue. So I'm going to go ahead and put one glove on so I can go in and examine the patient's mouth. I'm going to get them to open their mouth and say, ah. I'm going to be looking for 32 teeth if this patient is an adult. And I'm also going to be looking for any dental hygiene issues, if the gums are bleeding, if there's any teeth that are cracked, if there's any swelling or bleeding around the gums, could indicate gingivitis. So I'll just open their mouth, get them to stick their tongue out and say, ah. I'm going to look at the back of the throat as well to observe the tonsils to make sure they're not swollen or touching. So in a child, we would assess it, the 20 teeth are all in, and in the adult, like I said earlier, with 32 teeth, now that would be including the wisdom teeth, so we'd have to take into account, has this patient had surgery in their mouth before? Have they had their wisdom teeth removed? So that would be something that's important to mention. Also observing the tongue to make sure that there's no fissures. Ask them about their taste. Have they had any changes in things that they taste? Also going to be observing for white patches in the mouth. Could be leukoplakia, also could be related to a cancer. So those are important things to look for as well. Their jaw, we're going to want to palpate their jaw to make sure that there's no crepitus. So everything feels good there. Do they have any difficulty with swallowing or chewing? So those are also important things to ask and assess. Do they have any pain when they do this? And yeah, so then next we're going to move on to assessing the neck and the trachea. So we are going to assess that the patient's trachea is midline. Now there's a few ways that we can do that. First, I'm going to go anteriorly and just palpate and assess, and obviously inspect first, and it looks to be midline. And also I can assess the thyroid, so I can get the patient to sit up, and I can come in behind them and I can move the trachea left and palpate that way, and move the trachea right, palpate that way. Now this will be slightly discomfort, but there should not be any pain involved. Now I also want to palpate to find the thyroid. So I would look below the cricoid cartilage. I would palpate for that, and underneath that I should feel where the thyroid is, and I'm palpating that to see if there's any lumps, bumps, anything unusual, or pain or discomfort. So now we're going to look at the neck, and we want to make sure that the trachea is midline and that is free of redness, swelling, lumps, bumps, lesions. We can palpate. For the trachea, we'll go posterior. Rebecca, I'm sorry, my hands are freezing. And we're going to shift the trachea to one side, palpate, shift to the other side, palpate. If everything seems good, then we can move on. Now we're going to move on to the range of motion for the neck, which would just be, Rebecca's going to show you ear to shoulder, ear to shoulder. Extension would be back, flexion would be towards your chest. Now if somebody who is experiencing, what's that one called? Meningitis, this and that would be painful and almost impossible. So if that range of motion is not able to be done, then maybe that would be a concern of ours. So here's the beginning of our musculoskeletal physical assessment, and we're going to ask questions as far as is our patient on any medications? Do they have any family history of osteoporosis? Are they experiencing any pain in joints throughout any part of their body? Do they exercise regularly? Are they on any calcium supplements? Things such as just their general age, gender, their weight are really important, as women are more susceptible to osteoporosis. We're also going to ask of any excessive caffeine or alcohol intake. Are these people smokers? Do they use steroids? Or, you know, any general muscle stiffness or discomfort that they're having throughout their body.
Starting the musculoskeletal system, we observe the patient's stance and gait. It should be evenly distributed with an erect posture. Toes should be pointed straight, and the stride should be equal.
So now we're going to do the spine, and we want to make sure that the all the proper curvatures are in place. So in the cervical part of the spine, we want to make sure that that is concave, and the thoracic would be convex, and then the lumbar would be concave, and then we have our sacrum and our coccyx. So we just want to make sure that that is all in a line, that there is no lateral shift, which could indicate scoliosis. If maybe Rebecca was heavily pregnant, there may be signs of lordosis, which is just an exaggerated lumbar curve. Also, we can just take a look to make sure everything's symmetrical. All right, all looks good. So Rebecca's going to demonstrate a few range of motion activities for the spine to ensure that everything is in order and that there's no pain present. So first we're going to do flexion, which would be touch your toes. So Rebecca can do that just fine. So an extension would just be straight up or lean back. Now we just want to show the right and left lateral bending. So there's your right and your left. Perfect. So with her feet planted on the floor, she's going to rotate her upper body 30 degrees. And there we go. Perfect. Each way. Very good. So I'm going to start the assessment of our patient here with the hands. And firstly, we're going to observe for any nodules, any deformities, any masses. And then we're going to palpate each joint of the finger from distal to proximal. All the joints, all the joints. We're also palpating to see if we're eliciting any pain. Then we are going to go through some range of motions. I'm going to sort of do the fingers, hands, and wrists all together. So range of motions for the fingers would be, we want to abduct and adduct the fingers. We want our patient to do that. We want to make sure that they're able to do that. We want them, as far as the hand and wrist, we want them to be able to also adduct, which would be adding towards the body, or abduct, which would be away from the body. So our patient is feeling a little stiff today, but should be able to do those range of motions. So along with more range of motion for the hand and wrist, we want to be able to do flexion and extension. So flexion and extension, flexion, extension, and there we go. We can also elicit what's called the Allen's test, which is for to show vascular flow of the body, making sure that there's adequate blood flow to the hand and the extremity. And what you would do there is you would just occlude both of the radial and the ulnar pulses, and then you would let go to make sure that the hand goes back to pink. So when you occlude, the hand will blanch, and then when you let go, the hand should return to a nice pink color.
This is a demonstration of the Allen's test, where both arteries are occluded and then they are let go to demonstrate the blood flow back into the hand. These are examples of flexion, extension, abduction, and adduction.
So we're going to move up to the elbow, and we want our patient to be able to flexion, extension. Obviously, first we're going to inspect to make sure there's no lumps, bumps, lesions, any abnormalities, any sign of a bursa, and everything looks good. Skin is intact. We want to put the elbow through range of motion. So we'll do flexion and extension. Also part of the elbow range of motion is pronation and supination. So pronation would be like that, and supination would be palms up. So we want to make sure that they're able to do that and no pain or discomfort when doing those.
These movements show flexion, extension, abduction, adduction, supination, and pronation.
So now we're going to move on to the shoulder. The shoulder is a really complex joint, so we're not going to go too in depth, but we are going to firstly observe for symmetry. If there is any dislocation of the shoulder, that will be visibly notable upon inspection, and also the patient would be in a lot of pain. So firstly, I'm just going to palpate along the clavicle, starting at the suprasternal notch and moving laterally across. And I'm just palpating with the tips of my fingers across until I reach the acromion process. And this is where the scapula and the clavicle meet right about here. So now we're going to do a few range of motion activities for the shoulder. So flexion would be out here, and extension would be out behind the back of the body. We will do internal and external rotation of the shoulder. We will do, adducting and abducting. I got that wrong. Adducting and abducting of the shoulder. And again, if this elicits any pain, this could be indicative of a rotator cuff injury.
These are examples of flexion, extension, abduction, adduction, and a full rotation of the shoulder.
So there is such thing as a scratch test, which would also show us if there was any injury to the rotator cuff, which we're going to ask our patient to take their arm. This guy's a little stiff, so I'm going to use my own self. And we would get them to take their hand, go onto the opposite side and see if they can scratch their opposite scapula. And same as this way, we would take their hand and get them to scratch in between their shoulder blades or in between their scapula there.
So when assessing the hip, we should first of all ask our patient to take off their clothes, which we're not going to do here. And we want them to do several exercises. So first we want to start with extension, which is bringing the foot forward, and then flexion, which is bringing the foot backwards. We also want to see if they can take their leg and put it, you can stand straight, put it in the abduction, which is taking the leg away, and then putting it in the adduction, which is towards the midline. After we have assessed that, we can then get them to do an external rotation with their hip and then an internal rotation with their hip. So to continue our hip assessment, we would ask our patient, while providing privacy, to bring up their leg to a 90-degree angle, bring it back down, and then to bend at the knee at a 120-degree angle, and then we would ask them to abduct at 45 degrees and adduct at 30 degrees. Continuing these range of motions, we would also ask our patient to do an internal flexion and an external flexion. Our patient is a little stiff right now, but hopefully he'll loosen up later. So I'm going to start my knee assessment. First we're going to assess for any swelling, redness, edema that is in the area. And then we want to palpate the medial side and the lateral side to see if there's any bony prominences, once again swelling, and see if there is any abnormalities. We can give the patella a little bit of pressure there and to see if there's any fluid behind it. We would know if there was fluid behind it if you could feel it actually.
Yeah, it would displace, I believe, like it would displace, yeah.
I'm also going to palpate on the medial and lateral sides of the meniscal groove, which is also known as the shock absorber, to see if there's any indentation, which could mean that there is a tear. So for range of motion for the knee, I'm going to get Katie to extend, flex.
Perfect.
And then she's going to abduct and adduct. And that looks great. So now we're going to be assessing the foot. So we're going to palpate the medial and lateral malleolus. And we're making sure everything is intact there. And then we're moving down to the calcaneus, which is known as the heel. And we're slowly palpating towards the tarsals, and then to the metatarsals, which are your toes. We also want to demonstrate some range of motion here, so we want to try the dorsiflexion. And dorsiflexion should be about 20 degrees, and plantar flexion should be 30 degrees. We also want to try inversion and eversion, and that looks fine.